Vijay? Vijay?
Yes, sir. Good evening.
Good evening. Good evening. ഇപ്പൊ ഇവിടെ കുഴപ്പമില്ല. ഭയങ്കര കാറ്റും മഴയായിരുന്നു. ഇപ്പൊ മാറി. ഇപ്പൊ കുഴപ്പമില്ല.
Okay.
Vijay?
Sir.
Capital J and small j at 2020 ആണ്. Capital J and എന്ന് വെച്ചാൽ ഈ എംബ്ലം ആണ്. മറ്റേ ഇത് സിമ്പിൾ. Capital J and small j @2021.
Okay.
ചെയ്യാൻ പറ്റുന്നുണ്ടോ യൂട്യൂബ്?
നോക്കാം സാർ.
ഇന്ന് എഴുതി വെക്കണേ. ഇനി എല്ലാ പ്രാവശ്യം ചോദിക്കാം. ഒന്ന് എഴുതി വെക്കണേ.
ശരി സാർ.
ജോസഫ് പിള്ളേര് എക്സാമിന്റെ കാര്യം പറഞ്ഞ് വിളിച്ചിരുന്ന
ഏത് പിള്ളേര്?
UG.
എന്താ പ്രശ്നം?
എന്തോ മെഡിസിന്റെ പരീക്ഷ എന്തോ മാറ്റി വെക്കുന്ന കാര്യം എന്തോ
എന്നെ വിളിച്ചിരുന്നു.
ആ ദിവസം ഒരു ക്ലിനിക്ക് ഉണ്ട്.
എന്താണ്?
ക്ലിനിക്കൽ എക്സാം ഉണ്ട്. ആ ദിവസം ഒരു ക്ലിനിക്കൽ എക്സാം ഉണ്ട് നമ്മുടെ പിള്ളേർക്ക്.
അത് 13-ാം തീയതി അല്ലേ? 13-ാം തീയതി.
ആ ദിവസം അവർക്ക് എക്സാം ഉണ്ട്.
എന്റെ ഇടയ്ക്ക് നമ്മുടെ പത്മകുമാറിനൊന്ന് വിളിക്കട്ടെ. ഞാൻ വിളിക്കാൻ പറ്റിയില്ല. ഞാൻ രാത്രി വിളിക്കാം. പത്മകുമാറാണ് പറഞ്ഞിരുന്നത്. നമ്മൾ നേരത്തെ അങ്ങനെ പോസ്റ്റിംഗ് തുടങ്ങിയപ്പോ തന്നെ പറഞ്ഞിരുന്നു അങ്ങനെ പരീക്ഷ പറ്റത്തില്ല, നേരത്തെ പരീക്ഷ നിർത്തണമെന്ന്. അവര് നടത്തിയിട്ടില്ല. അതാ കാര്യം.
ബാക്കി എല്ലാ ഡിപ്പാർട്ട്മെന്റും 2 ആവറേജേ നടത്തിയിട്ടുള്ളൂ. ഹോൾ പോർഷൻ ഹോൾ ബാച്ച് എക്സാം ഒന്നിച്ച് നടത്തിയിട്ടില്ലെന്ന് പിള്ളേർ പറയുന്നു. മെഡിസിൻ മാത്രമേ നടത്തുന്നുള്ളൂ.
നോക്കാം. ജോണി സെബാസ്റ്റ്യൻ. ജോണി.
സർ. ഗുഡ് ഈവനിങ് സർ.
എവിടെയാണ്? ഡ്യൂട്ടിയാണോ? ഫോട്ടോ ഇടാത്തത്?
അല്ല.
ഫുൾ പ്രോഗ്രാംസ് ആണ് സാർ. 7 മണി മുതൽ 10 മണി വരെ പ്രോഗ്രാംസ് ആണ്.
വേറെ എവിടെയൊക്കെ പ്രോഗ്രാം?
എല്ലായിടത്തും കയറി ഇറങ്ങണ്ടേ. 8:30 കോഴിക്കോട്.
8:30 കോഴിക്കോട്. എങ്ങനെയാണ് ശ്രീപ്രസാദ് ഇന്നത്തെ പ്രോഗ്രാം? എങ്ങനെയാണ്?
നമ്മള് ജസ്റ്റ് ഒരു ഇൻട്രൊഡക്ഷൻ പറഞ്ഞു സാറിന് തരുന്നു. അതിനുശേഷം
ജോണി സംസാരിച്ചിട്ട് പൊക്കോട്ടെ. ജോണി പിന്നെ വേറെ സ്റ്റേറ്റിലുള്ള വേറെ സ്റ്റേറ്റിൽ നിന്ന് ആരെ കയറിയേക്കുന്നത്?
ജോണി സാർ വരും. വരുന്ന സമയത്ത് കൊടുക്കാമെന്ന് പറഞ്ഞു.
അപ്പൊ ജോണി സംസാരിച്ച് പോകട്ടെ. ജോണിക്ക് പോകണമെന്നുണ്ടെങ്കിലേ പ്രോഗ്രാം ഉണ്ടെങ്കിൽ പിന്നെ ജോണിക്ക് മറ്റിടത്തും ജോയിൻ ചെയ്യാമല്ലോ.
നമുക്ക് തുടങ്ങിയാലോ? സമയം കളയാതെ. കുറവാണ്. അല്ലെങ്കിൽ സാറങ്ങ് പറഞ്ഞു.
അല്ലല്ല, നീ
So respected teachers, seniors, my dear IAPians of Alappuzha district and dear friends, without wasting much time, we are directly going to our monthly GPN CME of April, and today it's World Health Day. Along with our program, almost I think 7 out of 22 branches of IAP Kerala, they are doing activities in association with World Health Day observation. So our state secretary and state president, they have to attend almost all activities and programs, and because of this I invite Dr. Johnny Sebastian to give a felicitation for Alapi team.
Good evening all. Respected President Dr. Sri Prasad of AAP, my very good friend and guide and a national leader from AAP, also the chairperson of the Alapi chapter, Dr. Jose sir, Secretary Reshma, my friends like Dr. Anil, Dr. Sangeeta, seniors and dear colleagues. Also, let me thank AAP for giving me an opportunity to felicitate on this occasion of World Health Day. I'm extremely delighted to see that IAP Alappuzha is doing extremely well, conducting CMEs every month regularly now, and with good participation. And today, as part of you have selected and pediatric autoimmune encephalitis, which are very useful for practicing pediatricians. I wish this CME all success. Thank you. Jai Hind, Jai IAP. Thank you.
Thank you,
Sri
Joni
Prasad.
sir. Yes, thank you, Joni sir, for attending our program. And on the behalf of Alappuzha Academy of Pediatrics, I also invite Team Aster Medicity, who are the sponsors for today's program. I think our speakers are ready and almost joined here, Dr. Davidson Devasia and Dr. Amito Singh. And I also welcome Dr. Vishnu Mohan, the representative of Aster Medicity, for organizing this academic program for our team. And today, it's World Health Day. The theme for this year is to build a good and a fairer world to all. That is, everyone should have access to a quality healthcare system irrespective of their socioeconomic status. In a country like India, we are having both government and private sector healthcare workers. By doing some combined efforts, we can do well like we did and doing in COVID-19 situation. The pandemic is still in aggressive mode, with its second wave hitting more than 1 lakh people within 24 hours and pushing more people into poverty and other issues. Many families are getting very less income, and thus it ruined our economy. It damaged our schooling system. From one side, our small children, they are getting frustrated and bored with these virtual academic sessions, while on the other side, the grown-ups and adolescents, they are enjoying and getting addicted to the internet's magic. Some are not getting clean water and some are facing food insecurity. So there are existing challenges like gender inequality. So in such a condition, if healthcare services are reachable to all sections of society at primary level, we can detect various diseases at initial stages. Citing Kerala, a good model, prevention healthcare is the best one can do to build a healthier society. And inspiring today's team, Alappuzha Academy of Pediatrics is also planning to conduct some medical camps to those children from difficult to reach areas and are unable to attend our specialty clinics at a medical college. But the second wave is a dilemma, and I think once it is getting settled, we will proceed into that. And in this occasion, it's a privilege and honor to be a part of IAP Kerala, who is always in the forefront of all major health activities in association with health. So without wasting much time, I request our Joe sir, who is our celebrity icon and executive board member, to moderate the session. Over to you, Joe sir.
Thank you, Sri Prasad, President IAP, Alappuzha Branch, Secretary Dr. Reshma, Sales Secretary Dr. Joni, and HOD, our own HOD Dr. Shanava sir, our senior IAP members of AAPs, today our faculty Dr. Amito Singh and Dr. Davidson and Devasia. And in this era, in the evening, I want to congratulate the AAP team because once Dr. Sri Prasad and Reshma took over the charge of AAP office parents, we having a excellent academic as well as social activities in all days and celebrations conducted by Sri Prasad and Reshma. With a big congratulations to Reshma and Sri Prasad for the excellent activities. And the thing is that AAP in the last 3 months conducting regular and scientific activities for the academies for the AAP members, that was well attended by most of the AAP Kerala members for last 2 scientific meetings. And today we are celebrating the World Health Day, and AAP Alappuzha Branch, Sri Prasad and Reshma arranged a series of activities, and I think Reshma today has conducted some activities in the health activity, and Sri Prasad is also conducting various activities, and all the members of the AAP conducting supporting and interesting conducting the activities of the AAP activities. And today we are, as Dr. Sri Prasad mentioned, today the era of internet use of study for the students, and even the students are facing lot of issues. Apart from psychological issues, they are without any physical activity because they are logged in their own home. They are going to school. They are staying there with at home with the food and everything. They are addicted to the net because all this academic activities of students are going on this internet access. So there is non-communicable disease. I think we in the coming era we have to face a lot of issue in non-communicable disease. Today the AP selected the one of the important issues we are going to discuss: the hypertension in children and autoimmune encephalitis in children. These are the two scientific activity academics we are going to have. And to to talk on the hypertension in children, that we have an excellent faculty from Aster Medicity Kochi, Dr. Amto Singh. He is a pediatric cardiologist and pediatrician for last 7-year experience, and he is specialized training in advanced international cardiologies and complex and treatment of complex congenital heart disease. He is a fellow of National Board Examination Pediatrics and fellow in National Pediatric Cardiology, and is trained in non-surgical closure of PDA, AST, VST, and balloon dilatation of pulmonary and aortic valve, and duct sending in cyanotic children with duct-dependent pulmonary hyperculations. He is especially interested in fetal echo. He is worked as a consultant pediatric cardiologist at Paras Hospital, Panchagula, and consultant pediatric cardiologist at Chaitanya Hospital, Chandigarh. Now, at present, he is working as a senior pediatric cardiologist at Aster Medicity Kochi. With these words, I invite Dr. Amito Singh to give a talk on hypertension in children. And there is one of the important issues we are going to face in the COVID era. We are going to face in children pediatric age groups. So over to sir. Amito Singh, sir. Welcome, Dr. Jayaraman, sir, our state president. You are in time. Just we are going to start our academic activity. Before Amit Singh and Dr. Jayaraman, sir, is our IAP state president. So before going to start our scientific meeting, because our president have a lot of program today in other different branches. So with one words, I invite Dr. Jayaraman sir to word regarding the World Health Day celebration for AAP Alpra branch. Dr. Jayaraman sir, before going to scientific program. Jayaraman sir, please.
Good evening. Thank you, Dr. Jose, Dr. Sri Prasad, and Dr. Reshma for inviting me for this World Health Day function of the LAP branch. I'm very happy that you are conducting so many programs, and LAP has become one of the big, very active branches under the new leadership. And today being World Health Day, we are having you are arranged a good program, good CME in connection with a major issue, an upcoming issue, that is hypertension in children. And I wish the very best for the program. As you are aware, this year's theme is health equity, which is not there from time immemorial. And by the virtue of their birth, by virtue of the birthplace, by virtue of who are they, and by virtue of the opportunities, many people are getting so many facilities regarding their health issues, whereas a lot of people, a majority, is not getting even the basic needs for their health. And World Health Organization has called for equity, and they have called the world leaders to act for a equitable distribution of health and work for the issue this year. And I once again thank you for inviting me for this function, and wish the very best for the CMEs to follow. Thank you so much.
And now I invite Dr. Amito Singh. Amito sir. Thank you,
Am I
Jairam sir,
audible?
for attending our session. Amito sir.
Yeah, I'm audible, sir.
Yes, sir. Audible.
Yeah, okay. Let me share my. Uh, can you? I have been disabled to share my screen actually. So
Actually, I will
can you allow
help
me
you,
to?
sir. We will help you, sir. Vijay Krishan. Vijay. അതൊന്ന് ഷെയർ ചെയ്യണേ, മറ്റേ ഷെയർ ഓപ്ഷൻ കൊടുക്കണേ സാറിനെ.
പോസ്റ്റ് ആക്കിയാണ് അല്ലേ?
പോസ്റ്റ് ആക്കി കൊടുത്താൽ മതി.
Meanwhile, Shanawaz sir, few words. Shanawaz sir.
And also our IMA Alpha branch president, Dr. Mohammed sir, also there. Shanawaz sir plus.
Okay. So, very good evening to all. First of all, so Dr. Sri Prasad and Dr. Reshma has brought our AAP to highlights. Today, Dr. Reshma had on health activity. In a walkathon for about half an hour to 1 hour. And now after that there is there is going to be an academic feast. So one of the most important topic in hypertension, which is not very well investigated, because of the most of the pediatrician usually will not use BP for their detection in their routine practice. So this is usually underdiagnosed, because even nowadays there are a lot of cases because of the obesity and inactivity, especially in the COVID era. There is so much inactivity, so there is a higher incidence of hypertension is there. That will be followed by one of the evolving problem, that is autoimmune encephalitis. So two important topics. So I wish all the best for the both the topic. Thank you.
Thank you, Shanawaz sir. Amito sir, now can you share?
Yeah, sure. And now I can share. Thank you. Is it visible, sir?
Yes, sir, yes, sir,
Visual, sir. It's coming. Okay. Put on slideshow, sir.
Just a minute. Good evening to everyone. So I'm IPLP to invite to give a talk on World Health Day on hypertension in children. This is when I was practicing in pediatrics. Even I also not importance. I have realized it now. If we overall, prevalence of hypertension is continuously increasing in the pediatric population, and if to see the prevalence of is around 3.5% of the pediatric children are suffering from hypertension. And now in 2017, when American Academy introduced the term elevated blood pressure in case of pre-hypertension, the incidence is still around, prevalences are still around 2.2 to 3.5%. And it has been found to be more commonly in boys, as compared to girls. Around 50 to 19% of the boys are having hypertension, and majority of children are with overweight and obesity. This is a great, the cause of this rising trend is also mainly because the incidence of overweight and obesity is in pediatric population. So if we, I'm stressing also because on this prevalence and obesity related hypertension, because it is in the health day, we should think of that we should try to focus on these children and to try to modify them so that they don't become hypertensive in adulthood and they don't land up with the adult cardiologist much in the early younghood life. So if we see to this study also, we see that a relationship of obesity and hypertension is that the prevalence of hypertension increases with obesity, and around 3.8 to 24% of the obese children are found to be hypertensive. And this increases as the BMI percentile increases. So if we even see in this study also, as the BMI is increasing, so the incidence of hypertension is more. So once the BMI crosses 95th centile for the hypertension, the incidence percentage is around 34%. And it further increases. There are few more studies which are shown that after once it goes to the 99th centile, the incidence of hypertension is again increases about 2 times as compared to what it was between the 90th and the 95th centile. There has been beginning because there's and it increases with increase in adiposity. Also, normally if we see this, if we see the ambulatory blood pressure monitoring reading, we will find that there would be a nocturnal fall of blood pressure is there, but this fall doesn't happen in obese children. Maybe because of an obstructive incidence of obstructive sleep apneas increases in them, or because of the arteries becoming more stiffer. And, and if presence of associated additional risk factors which are a part of a metabolic syndrome like diabetes and dyslipidemia further worsens it, and it tends to further increases the chances of developing hypertension in obese children. There was a heart study which was found done in about a number of about 1,500 children, which is called as the Strong Heart Study, which was especially more focused with American Indian children. And they found that the prevalence of LVH, left atrial dilatation, both reduced LV systolic and diastolic functions, was much higher in those who had a comorbid conditions. That is a part of the metabolic syndrome, that is diabetes and dyslipidemias. These group of children had a higher prevalence of left ventricle heart. So that means the end organ damage which is happening because of hypertension is much more in this group of population than those who are just obese but not having diabetes or dyslipidemias. This was a wonderful slide which I had borrowed from one of my colleagues, and it was showing that they had evaluated the obese children and had followed them up about 23 years of follow-up, how these obese children who become obese adults and their likelihood of developing this hypertension, diabetes, hypertriglyceridemia and dyslipidemias. So we see that the chances of developing, as from this figure, the chances of developing diabetes was much higher, followed by if we all do club together, the dyslipidemias were also much higher. So the chances of developing coronary artery disease increased. And in addition to it, second to it, it was 2.7. This was in comparison to the relative risk was just 1 in case of non-obese individuals. And so it tells us how important it is to pick up these obese children, obesity and hypertensive children in earlier life, so that we can modify them and the chances of developing diabetes incidence or relative risk would reduce considerably. The second and most important factor which has been found to be causing hypertension, which increases its prevalence, is the sleep disorders breathing. This has been found to be increasing, especially those who are obese. Again, it is all correlated to obesity, but in addition to it, those who have a microganthia, adenoids, who have an obstructive sleep fragmentation. So they have an increased incidence of hypertension ranging from 12.6 to 14%. And it was shown in this meta-analysis that there's a strong association between disordered sleep breathing and hypertension. So it is especially more common with obstructive sleep apneas. And this has been, if we have a patients who are with obstructive sleep apnea, who are obese, who give us a history of snoring, we must undergo a sleep and must check their blood pressures because we will find chances of picking them up would be much higher. As we know, chronic kidney diseases are found to be more hypertensive and is one of the major common causes of hypertension in children. About majority of them, 50% of them would be hypertensive, and they have around 20 to 70% will have an uncontrolled hypertension. So, and 20% of the total pediatric hypertension is attributed to chronic kidney disease. But now, but this was with the previous strata, but now even because as the obesity and is also increasing, the chances of which primary hypertension, which was much less common in children, is also increasing day by day. And what in our routine practice, we are seeing it, much more number of children and adolescents who are obese are found to be hypertensive these days, and majority of them have primary hypertensions. There's another prematurity is another risk factor which has been limited with correlated with hypertension, especially preterms, because now the number of preterm deliveries, preterm babies who are saved is much more as our neonatal care has improved considerably. We can but this group of population has not been very well studied if we see it, but they have a high prevalence of about 7.3% because there's a loss of circadian blood pressure patterns in these group of individuals. Also, as we know, there's the chances of umbilical artery catheterization in these group of individuals, which leads to possibly, which increases the incidence of hypertension. So if we must take a thorough history of when evaluating a child, that if a child is premature, we should check his blood pressures. And this is one of an indication that we need to check the blood pressure even less than 3 years of age. Normally, if the this new guideline said all children above 3 years we should see, but children who are premature, we should get the blood pressure monitored even less than 3 years of age. So why we are so, what's the importance in diagnosing hypertension in children? There is, as what I have told you, that they have a high incidence of developing diabetes, obesity children, hypertension continuously. But even then, those who are non-obese also, if they have a hypertension, it has been shown that if we are tracking the blood pressure from childhood to adulthood, they demonstrate a child who has a higher BP in a childhood will continue to have a high BP in adulthood, and also a higher onset of hypertension in young adulthood. So therefore, the risk of cardiovascular diseases like coronary artery diseases goes much higher. And it's this strength of tracking association much higher those who are in older children and adolescents. Which was quite proven in the meta-regression analysis, which was published in Circulation 2008. And this was a wonderful study which was published by Theodore F. And was published in the Journal of Hypertension in 2015, which showed, they had, this is a very important graphical representation, which they have seen in the children, that they monitored the blood pressure at around, started monitoring the blood pressure of children between 7 years to 38 years continuously. And they were found that those who, if we see in this graph also, those who and it was done with between the 95th confidence intervals. So if we see that those who are at 7 years, those who are pre-hypertensive, or those who are pre-hypertensive or what we call an elevated blood pressures, or those who have a high blood pressures. So if we see the statistics, if this graph line, we see those who have especially who have a high blood pressure around between 7 to 10 years of age, there would be a steep rise in the blood pressure after about 11 to 18 years of age, and it continues to do so as they go into adulthood. So this tells us there's a strong association that the high blood pressure in childhood will continue. These children will continue to remain have high blood pressure throughout their adulthoods. So if we try to intervene at this point of life and try to do a modification in the form of lifestyle, dietary, or any other factors, or a drug treatment if it is required, we can bring it down, and definitely the patient may not have a high blood pressure in his adulthood, and we might prolong the development of cardiovascular diseases, which is not fully known at how much damage it is causing at this moment, but definitely it's a kind of a preventive therapy which we're going to do if we are picking this group of children and treating them. So how to define a blood pressure? It is, as you know, it is just if it is a normal blood pressure, it is between the 90th centile for age, sex, and height. Now the new charts have come up. Now this is a new term which is called as an elevated blood pressure in term of pre-hypertension. That means if a systolic or the diastolic blood pressure is greater than the 90th centile to less than the 90th percentile, or 120/80 to less than the 9, whichever is lower. And stage, another classifying, once it is hypertension that is above the 90, equal to or above the 95th centile, it is hypertension. Then hypertension children are further staged into stage 1 and stage 2. So this is a new entry, that is once is 95th centile to 95th centile plus 12 millimeter of mercury, or 130/80 or 139/80, whichever is lower, we classify as stage 1. Those who are greater than 95th plus 12 or 140/90, children between 1 to 13 years of age, will be labeled as stage 2. But above 13, following the adult guidelines, that is elevated BP is between 120 to 129, and stage 1 is 130/80 to 139/89, and more than 140/90, it is stage 2. So it is above 13 years, we have to just follow this. We do not go by a percentile charts. It is only 1 to 13 years we need to go by the percentile charts. Below 1 year, also there are neonatal charts are available, and we follow the same criteria over there. So this is just a clip of the chart which was showing that, like for example, 11 years old. So there would be an height would be there, and both in inches and centimeters, and the height centile based on what is the measured height, and we plotted at which centile it is falling. So based on that, we see where the systolic blood pressure is falling. So we have introduced into the new charts the 95th plus 12 millimeter of mercury as an additional reading also. So we can see, as you can see over here, the 95th centile is 118, and 95th plus 12 is 130. So this group of, this is a part which is going to be in stage 1 hypertension. In addition to it, not for the doctors, but for the nurses and the healthcare individuals, the screening BP charts has been introduced. This is a much easier tool for any in a community health center or anywhere, which could be so that anybody can pick up a child that his high blood pressure is high. So this is based on those who are above the 90th centile with the 5th centile for high, and it has a negative predictive value of about 99%. So it's according to this is a single figures. If we can pick it up, the sister can pick it up and tell us that this child is in the elevated blood pressure, then we can evaluate it him take further readings by a doctor himself, and thus the pickup rate would increase. So what are the basic BP measurements? It is just one should be in a quiet room for 3 to 5 minutes, measured in a right arm. The bladder, the cuff, this is most important, is a cuff size, that it should not be too small or too big. Too small will overdiagnose it, too big will be underdiagnosing it. and we should measure it. And the cuff size should be at least, the width should be around 40% of the mid-arm circumference, and the bladder length should be covering around 80 to 100% of the chest. This is the method to how to assess the cuff size. If we are not very sure which cuff size to see, that we ask the patient to sit, fold his elbow at right angles, and then take the point between the acromion and the olecranon process, midway between them, and measure the arm circumference. And based on that, we say around 40% of the width will take the bladder width. It's important, and we can have different types of bladder. This is just an example to show you the bladder, the cuff which is available, and different sizes are available, which tells us which, and there's a figure over here which tells us the length and the width of the cuff. So once we have taken a blood pressure and see if it is more than the 90th centile, we should remeasure it twice and take an average of it. And based on that, and once we can use it both an oscillometer as well as an oscillatory method. But now, since as the mercury has been banned, majority of them are using an oscillometer device in the OPT basis. So we can use both. But once you have found a high blood pressure in the oscillometer device, one should recheck it with an oscillatory method, because that is most important, because all our charts which are available and which have been published, they are based on the oscillatory method, not on the oscillometric method, because oscillometric method, it gives us the mean blood pressure, and it derives the systolic and the diastolic blood pressure out of it. And this value is slightly higher as what we are measuring on oscillatory methods. And we should take it twice. Once we have measured, then we should label it as a hypertension or a normal blood pressure, and then classify it further stage 1 or stage 2 hypertension. How frequently the BP needs to be measured? Any children above 3 years, we should see annually, with certain exceptions. Like above, we need to do it, so like on every visit, we should see children who are obese, who are taking medications, those who are renal disease, aortic arch obstructions, or diabetics. Children, as I told you before, the children less than 3 years of age, we need to blood pressure, who are premature, those who have with congenital heart disease, recurrent UTIs, family history of renal disease, those who underwent a transplant, bone marrow transplant, those who are drugs on blood pressure, or those who have hypertensive secondary to neurofibromatosis, tuberous sclerosis, or sickle cell disease. So these are the indications where we have to do it less than 3 years, but otherwise we have to measure it above 3 years of age. So after classifying what to do so if it is a normal, that's just an annual screening. If we find in an elevated BP, that is between the 90th to less than the 90th centile, or BP less than 120/80, then do initial assessment, call him after 6 months, give him counseling about lifestyle modification. Still after 6 months, you find him to having a high blood pressure, then you need to do a lifestyle counseling, measure check the upper and lower limb BP, undergo ambulatory blood pressure monitoring, diagnostic tests, certain tests, and subspecialty referral to hypertensive clinic if you feel so. If it is in the stage 1, you have to do just an initial lifestyle counseling, review after 1 to 2 weeks. If it is still elevated, check upper lower limb pulses, that's all, and call him after 3 months. And if there it is still found to be elevated, then we have to follow the same, that is, do an ambulatory blood pressure diagnostic and start with initial treatment. So it is after the 3 months of first diagnosing of stage 1 hypertension, we will start a treatment. But hence those who are in stage 2, which we need to be a little more aggressive, that is, you start with initially with the lifestyle and checked upper lower limb blood pressures, repeat or refer to a specialty within 1 week, and do a ambulatory blood pressure monitoring diagnostics, and then start the initial treatment. And we need to do it. So we need to be more aggressive, those who are in stage 2, but in stage 1, we need to do more counts about the lifestyles. And but I find that this is a major chunk which we are going to deal with it. And here we do, if with this lifestyle counseling that is doing a dietary, encouraging for physical activity, will help him to become a normal and follow this path. But as I told you, those who are in stage 1 on stage 3 months and stage 2 within a week, we need to send just a simple investigations, that is to monitor the urine, kidney function test, that is the creatinine, blood urea, electrolytes. You do a lipid profile and renal ultrasonography, those who are less than 6 years of age or those who have normal kidney function test. Those who are obese, we can do an LFT for the fasting lipid profile panel to rule out hyperlipidemia. Also check his fasting glucose or glycosylated hemoglobin to rule out diabetes mellitus. As I told you, because sleep, they have profound snoring and daytime sleepiness, as history is there, so we can perform a sleep study. Should be done. So these are just a screen. These are the screening tests. So that means a urine, a kidney function test, a lipid profile, and basically and blood sugar levels, which we need to examine in obese children, and lipid levels. So coming to the management, it's going to be just the diagnosis, evaluation for the etiology, and go for the treatment. So diagnosis is based on the history, his physical examinations, and so history is most important. That is, so basically we have to identify whether it is primary or secondary hypertension, what is the end organ damage it is causing, and additional cardiovascular risk factors. So from the history also, we can see if the age is more than 6 years, usually in stage 1, only systolic blood pressure is elevated, overweight and obesity is there, positive family history of is there, and of hypertension is there, and usually they are asymptomatic, they're more likely to be having a primary hypertension. Whereas secondaries are mostly in the prepubertal age, usually they're in stage 2, they're in addition to the systolic, their diastolic blood pressure would also be elevated, ambulatory blood pressures would show a loss of nocturnal depth, and quite of them are symptomatic, and they would be showing some features would be there. I'm not going to the depth of then all the features, what are the neurological congenital coarctations and all, but then the management would require a non-pharmacological and a pharmacological. Non-pharmacological in the form of treating obesity reduction, regular exercise, reduction of dietary intake of limited dietary intake of sodium, and preventing, avoiding smoking, alcohol, caffeine, and energy drinks, which are quite common these days. Pharmacotherapy we will institute in those who are symptomatically hypertensive, those who are in stage 2 hypertension, or those who are stage 1 hypertension without any evidence or end organ damage that persists even after trial of about 3 months of therapy, or 3 to 4 months. We should of non-pharmacological therapy, we can have stage 1, or those who are hypertensive with end organ damage, any stage of hypertension with chronic kidney disease, or any stage of hypertension with diabetes. These are the group of children. Those who, that means even if it's stage 1 with chronic kidney disease or stage 1 with diabetes, you have to start the treatment. So what would be a target would be to bring the blood pressure less than the 90th centile or 130/80, but it is much lower in those with chronic kidney disease less than the 50th centile. So what drugs we should prefer? We should, based on what is the underlying cause and the concurrent disorders, and what we are more comfortable with, the drugs which we are used to it. So even if you are dealing with, I see a hypertensive child who is obese, and I find it is because of primary hypertension. You always start with an ACE inhibitors. Really even angiotensin receptor blockers. As we are more comfortable in using ACE inhibitors. If the target goal is not CG, we can add a thiazide group of diuretics. But for those with the renal vascular, if it is like stenosis, then we are not going to use an ACE inhibitor. We are going to use a calcium channel blocker as an initial antihypertensive of choice. Also, with patients with coarctation of aortas, we will use beta blockers as our first group of drug, not ACE inhibitors. And those with chronic kidney disease and diabetes, of course, will have an ACE inhibitors as an antihypertensive of choice. Among the ACE inhibitors, we most commonly use enalapril, and we can use it. It is an FDA approved, as we can use it. It is a drug which can be used more above 1 month of age. Other than captopril, other fisnopril and lisinopril are only for. So you can always start with the lowest dose, that is with 0.08 or 0.1 milligram per kg, and keep on escalating till your target is achieved. The ARB inhibitors, it is only Candisatin, which has been approved to be used in children between 1 to 5 years of age in a dose of about 0.02 milligram per kg and going to a maximum of 0.4 milligram per kg. Another drug which I'm more comfortable is using a losartan, but preferably use it in children more than 6 years of age. As we know, if we are not controlling with an ACE inhibitor, we could add an hydrochlorothiazide in 1 milligram per kg per day. So going up to maximum of 2 milligram per kg per day. Calcium channel blockers. This is a good group of drugs where you find the ACE inhibitors are contraindicated, and like in, for example, you can use amlodipine. This is a very it does wonderfully well in children between 1 to 5 years of age, and starting with 0.1 milligram per kg and increasing to 0.6 milligram up to 5 milligram, it can be given. So I found it I personally use more ACE inhibitors if it is contraindicated. I'm more comfortable in using amlodipine. So I'm going to tell you this is one interesting case which I had the last year. It was in the month of Feb. So it was a 2-month-old child who came to us, and he was just a complaint of suck test cycles for 3 weeks, and he was having a mild difficulty in breathing for 3 weeks. So on the routine, the pediatrician found that everything he did and was evaluating, found everything was okay except a mild murmur was there. But he took the blood pressure, and the blood pressure was very high in his OPD. So, and he got an X-ray chest which was showing some cardiomegaly to him. But this child had a history of premature delivery at 32 weeks, but there was no history of umbilical artery catheterization, and he was found to be having a BP, as I told you, high BP. On examination, his weight was 4.2. It was pretty good. All peripheral pulses were palpable, so there was no evidence that he had a coarctation of aorta, no dysmorphic faces. But he had a high heart rate of about 170. And a respiratory rate of around 30, which not elevated, but he was definitely tachycardic, which I was finding him. Bilateral vesicular breath sounds were there. If I measured his upper limb blood pressure, which was 125 by 59, so he was having a systolic blood pressure was 125, and right lower leg was 113. It was elevated, but there was not much difference. It was not there between an upper limb, lower limb. It was not greater than 20. So the coarctation is ruled out from it. And there was on cardiovascular examination, S1 was normal, S2 had a loud aortic component, and there was a short systolic murmur was present, about 2/6. So if we see on this definition, he was hypertensive, and that too in a stage 2 hypertension he was in. And definitely there was a premature delivery, which was definitely a risk factor with this child. So just an echo was so this was echo was showing. Otherwise, it was an absolutely a structurally normal heart, except that he had a mild left ventricular hypertrophy was there. So then, but there was no coarctation of aorta, so it was basically a non-cardiac cause of hypertension. So we wanted to ask Ben for the further testing that we got his urine analysis done, which was found to be normal. Kidney tests were absolutely normal. even got a Doppler study for his renal artery stenosis, which was showing that there was an adequate flow in the renal arteries. But since the child was crying too much, they was not able to point out that is there any renal artery stenosis. So we thought of doing an MRI angiography of this child. As you can see in this is a cardiac, and this is a good aorta. So there is no coarctation of aorta. In this frame, we could see that there's a good, as you can see from here, that there was a good flow into, these are the kidneys and these are the renal arteries which are rising. And there's a pretty good, there's no stenotic segment. So the renal artery stenosis was, but an interesting thing was happened since this procedure was done under sedation, anesthesia. So what was there while they were when they completed the MRI, they were unable to extubate, and they found that there was a lower right lower lobe collapse. To be kept on ventilator, he needed to be started on IV antibiotics, and he was started on oral enalapril and oral propranolol because of tachycardia. So, so it is basically as infection improved, the lung opened up, the BP gradually became normal over a period of 1 month's time, and he was off hypertensives after 1 month. Although we had to give him 2 hypertensive drugs, but this child it was mainly because some evolving infection was there, which led to him this problem. His blood pressure was increased. So this was also a good eye opener that even some infective children can become hyper manifestation of. This was another case too. This was also very interesting. This is a 17 years old adolescent girl, which was referred to me with a referral with the BP with the pediatrician was around 152 by 102 millimeter of mercury. But when she came to me, there was a BP of 136 by 96 in the right arm with an automated BP device. And when I did an auscultatory measurement, it came to be 134 by 84. And the leg, it was around 169 by, I'll go back to this. So it was, leg, it was 169 by 98. So it clearly showed us that there was no coarctation. As if had it been a coarctation, the lower limb blood pressure is usually lower than the upper limb blood pressure normally. And she was asymptomatic, but mother gave that the history of snoring was there. There was a positive family history of hypertension and diabetes mellitus. So as I told you, but her weight was 83, which was on the 96th percentile, and BMI was 31.2, which also was in the 96th percentile, suggesting that she was obese. And apart from obese, there was history of snoring was also there. So this, if we see to this overall, if they had his systolic blood pressure is on a higher, was on a higher side as compared to the diastolic. So almost of the things were normal, except the lip profiles were abnormal. Echo showed mild LVH, ultrasound was there. So what we did, we ordered an ambulatory blood pressure and a sleep study, since the mother was giving a history of snoring. So what we found and this was an ambulatory blood pressure monitoring. What we got is that her blood pressure, mean blood pressure during the daytime was 156 by 101 millimeter of mercury. During sleep also, it was 131 by 77. So the high blood pressure load was around, systolic blood pressure load was around 81%. But there was, if you see over here this is around in the midnight, there is a fall in the blood pressure. So there's a nocturnal dip has taken place, which might not have taken place had obstructive sleep apnea would have been more prevalent in this age group, in this age patient. So, what was there from this ambulatory blood pressure recording? It is helping us to know. Initially, if we see the previous blood pressure, I would be keeping him in stage 1 hypertension. But after doing an ambulatory blood pressure, she is in stage 2 hypertension. And both his systolic and diastolic blood pressure is elevated. And so we have started on lifestyle modifications like lowering his BP, and also started on ACE inhibitors, lisinopril. She is still on, her blood pressure is controlled, but still she is overweight, and she's under me follow-up. So but I would just want to give in conclusion, must record a BP in the OP settings is most important for all of us to pick up these group of children. Thank you so much.
Thank you, Amitso Singh, for an excellent narration about the pediatric hypertension. What are situation you had to suspect a childhood hypertension? What are the background you had to take up to analyze such patient with looking for the hypertension? What are the scenario you had to look for, record the BP less than 3 years of age? And one question to sir, what's the role of pediatric ambulatory blood pressure monitoring in pediatric aspect is concerned? How often you can able?
Ambulatory blood pressure plays a very pivotal role in diagnosing a patient with hypertension. And we can do this in children who are mainly above 5 years of age, because below that, they don't cooperate it well. So I preferably keep it above 6 years of age because they're more comfortable. It helps in more aspects. One, in diagnosing a masked hypertension, where we at that moment of time, his blood pressure might be in an elevated blood pressure state, but if you overall see it, he would be in an stage 1 hypertension. It helps also in, like in the last case, what I still, we are able to even pick up different stages of hypertension we see.
Let's
If
say
there's
any
a
role,
second is with white coat hypertension.
any role of differentiating between primary and secondary hypertension is in a role for this one?
Yeah, ambulatory blood pressure has a role in staging in the blood pressure. As I said, in this case, if you redo it normally, you'll see it is in stage 1, but an ambulatory blood pressure monitoring with stage 2. Also, it is important when we are treating this patient. Once he's on hypertensive, we feel that blood pressure is well controlled, but then also we have to do an ambulatory blood pressure to see how, because when we are doing it, the patient might have come with taken a drug and his blood pressure is normal. So we feel that we try to lower it, but we should not be doing that. Once we should monitor the ambulatory blood pressure and see what is blood pressure parameter in about 24 hours. So the monitoring also is ambulatory blood pressure helps us to a great extent.
So another question is that what is the best management protocol you can follow in hypertensive emergency in children is concerned?
Hypertensive emergencies, you have to definitely go for, because you not be able to start him on oral therapy, you have to go for an IV ultra short acting drugs like sodium nitroprusside, for example, we need to start him. But as these, and try to lower the blood pressure to just about, in the first 8 hours, we should target around 25% reduction we should target. And try to bring it to the 95th centile in another 12 to 24 hours. This should be our approach. And this should be followed. We should not be in a hurry to normalize the blood pressure. Once it becomes in 95, the child will be absolutely okay, and the features of heart failure might be over. Once that is there, then we can shift him to an oral antihypertensives. This is the strategy which has to be followed. But we need to short acting drugs so that we can regulate it in our hand.
So another question in the chat box is in case of echo in a child, which oral sedative you to prefer if the child is not sedated properly?
Phos is the most safest drug to be used on OP basis. And we are also using that triclofos. It's quite very safe. You give initially with 50 milligram per kg, and then you can give another 50 milligram per kg. Usually it works well.
I think very beautifully explained regarding the different aspect of hypertension, how to manage and how to long-term manage under hypertension, and every aspect, how to monitor child. Thank you, Ms. Singh sir, for an excellent talk on the behalf of AAP Alappuzha branch.
Thank you so much, sir.
So now we are moving to next another important topic. Even though it is not a common thing, we are come across rarely in the autoimmune encephalitis. Even though it is even it's not a common thing, but anticipation is very important to make a diagnosis of autoimmune encephalitis. I think this entity is a new entity coming in the pediatric neurology aspect is concerned in, I think, 2002 or 2003, there is no entity like that. After that, the new entity is identified, autoimmune part of encephalitis. Now, different theories are put forward for the autoimmune encephalitis in pediatric age groups. So, to deal with the topic, we have an excellent academician and pediatric neurologist, Dr. Davidson Devasya. He is from Kerala itself. He has completed his DM from Prestige Institute, Amrita Institute of Medical Sciences, and he is very interested in pediatric neurology in every aspect, especially in autoimmune disease disorders and neurometabolic disorders and genetic disorders in pediatric neurology aspects. And he is after the fellowship in DM fellowship in pediatric neurology, he is worked as pediatric neurologist at a Prestige Institute, Father Mullais Medical College, Mangalore. Now he is working as a senior consultant pediatric neurologist, Austin Medicities. So to talk on autoencephalitis, I invite Dr. Davidson Devasya to give a talk on. Over to Dr. David Devasya.
Can you hear me now? Can you hear me?
Yes, sir. Audible.
Audible.
All right. Okay. Thank you, IAP Alappuzha and Astium Institute for this opportunity. And today's topic will be autoimmune encephalitis. And I have a disclaimer that none of this that I'm telling is foolproof. Since autoimmune encephalitis, as Sir has already mentioned, it's relatively discovered recently, and it's an ever-evolving branch in pediatric neurology. And I would say that we all would have seen herpes simplex encephalitis very commonly, but I would like to throw light that most of the herpes simplex encephalitis
the later acceptance of food will be better if you give it as early as.
So most of the herpes simplex encephalitis that we are seeing is probably autoimmune encephalitis. Now, what is autoimmune encephalitis? It's basically antibody against your CNS proteins, that is in the brain and the spinal cord. We have intracellular and cell surface antigens. These are the names of the intracellular and cell surface antigen, of which in pediatric age group, which is very commonly seen as NMDA, AMPA, GABA-B, and glutamate. And you may also have autoimmune encephalitis without neural antibodies. Now, in one study where autoimmune encephalitis was studied, NMDA encephalitis was the most commonly seen, and followed by GAD65, Casper, and LGI1. Coming to the sex ratio, females were predominantly affected by GAD65, and there was no sex predilection in NMDA or LGI1 and Casper. These are the syndromes, well-known defined syndromes in autoimmune encephalitis. This is just table put, but I would like to say that in pediatric, this is mainly in adolescent and adult. In very small children, we do not see a proper characteristic autoimmune syndrome. Coming to a case, it was a 10-year-old female who was normal and since 2 months had behavioral changes, decreased sleep, dragging on the right leg while walking, and fever since 2-3 months ago. On examination, vitals were normal, occasional confusion, milkmaid drip, and occasional dragging of the right leg. So occasional confusion, probably the child is in encephalopathy. Milkmaid drip, we would attribute it to chorea, and walking with occasional dragging of the right leg. That means it's not a constant dragging, it's an occasional dragging. So it is not a spasticity and it is not a rigidity. Rigidity and spasticity is very constant, and this is occasional dragging only. So probably it is a dystonia. So we have a child who's in confusion, encephalopathy, milkmaid grip, chorea, and walking occasional dragging, probably a dystonia. So we know that there's a basal ganglion circuit that is affected and not confusion. So what could be the cause? Since there was a behavioral changes, probably it is Wilson's, but dystonia, chorea involvement. Encephalopathy, what is the cause? We'll have to work up. It could be a Hashimoto's encephalitis or autoimmune encephalitis. So considering that, we worked up with our routine metabolic workup, and workup for chorea was negative, basic vasculitic workup was negative, thyroid antibodies were negative, MRI was normal. We did a CSF. CSF showed 150 cells with lymphocyte predominant, normal protein and sugar. CSF cultures and CSF meningoencephalitis panel was negative. So that is the situation. And the next question is, when a child like this comes, when will you suspect autoimmune encephalitis and how do you work up? When do you suspect? You suspect it when there's a subacute onset of a neurological symptom, unusually high seizure frequency, seizure that is not being controlled by antiepileptics, very variable seizure, and there's a personal history or family history of autoimmunity, and or if there is a history of past neoplasia. Workup first is MRI. You may give a contrast, blood test to rule out infective and metabolic causes, urine test for any drugs, excretion, toxicology screening you can do if a part of the encephalopathy. Lumbar puncture, you look for the cell counts, you look for the protein, lactate, even metabolic causes like mitochondrial can simulate like this. Occasionally look for oligoclonal band, you look for CSF proteins. Oligoclonal band just shows that there is intrathecal, that is, there is increased CSF protein production. So which can be seen in many neuroinflammatory conditions. Rule out for infections in the CSF. Respiratory tests, nasal swabs can be done to rule out viral infection, EEGs, supportive test. Then you do the blood tests, which are very specific. You do the antibodies in the blood, you do the antibodies in the CSF. You can do a neurocognitive assessment also. Now, antibodies commonly seen in pediatric autoimmune encephalitis. This is just commonly seen. That is GAD65, MOGS, NMDA, and which are less frequently seen as dopamine 2, GABA A, GABA B, and glycine glutamate. And why do we have criteria for adult, and why do we need a pediatric criteria? Because pediatrics are not adult. Pediatric is never an extrapolation of adult. Pediatrics have a different presentation rather than what is seen in adult. So usually they do not fit into any specific criteria. In adult, you have stiff person syndrome, you say that this is LGI1, or you have certain characteristic, but this pediatric children just doesn't fit. It's very difficult to fit into a syndrome. For example, children with NMDA present with movement abnormalities, agitation, insomnia, seizures. But in adults, they're present with memory deficit and psychiatric manifestations. So these are the known syndromes of autoimmune encephalitis which doesn't fit into pediatric population. So proposed classification, this is one of the important slides on this talk. Proposed classification by the American Academy of Neurologists. This is a 2020 latest article. It says that if anybody who has subacute onset of neurological symptoms or psychiatrical symptoms in less than 3 months, it may be autoimmune encephalitis. So we have a possible, probable, and definite. Definite means the antibodies for the specific autoimmune encephalitis antibody like NMDA is positive. So that is the specific, that is definite. Probable means the antibody is not positive, but you have the rest of the corroboratory evidence, and possible is only on the clinical evidence. So clinical evidence features, if any of the two clinical evidence is there, it could be a autoimmune encephalitis, that is altered mental status, or altered mental status could be reflected on the EEG as slowing. So EEG is a must. Focal neurological deficit, cognitive difficulties, acute developmental regression, movement disorders except tics, psychiatric symptoms, seizures unexplained. And you look for CNS inflammation. The evidence of CNS inflammation through CSF is leukocytosis and or oligoclonal band. Oligoclonal band just shows that there is increased intrathecal, increased brain production of antibodies. You may have increased protein in the CSF. You may not get a normal CS. You may not have increased CSF proteins. MRI features of encephalitis. MRI shows some MRI findings I'll be showing. Brain biopsy shows inflammatory infiltrate. So if it is possible, if none of this is available present, it is probable if more than one feature is there, and it is definite if any the known antibodies is present. And autoimmune serology, when it is present in the serum and or CSF, it is definite. And one feature which should be noted is when you have a definite known antibody like NMDA positivity, you don't need an MRI finding, you don't need a CSF finding abnormality at all. Coming to NMDA encephalitis, NMDA receptor is a glutamate receptor. It is basically present in the frontotemporal region. Just remember, like the frontotemporal region, the forebrain, hypothalamus, pituitary, and limbic system. And these are involved in your behavior, learning, and memory. And this goes for a toss in NMDA encephalitis. NMDA encephalitis, we have seen, we would have treated, and common clinical features are psychiatric seizures, movement disorder, language, memory, sleep, consciousness disturbance. You may have paralysis, ataxia, sensory disturbance, central hypoventilation, behavioral changes, and dysautonomia. You may have association with anti-NMDA encephalitis of thyroid antibodies. You may have MOG antibodies. MOG is basically a demyelinating disease. So there was a child who had presented with ADEM and whose NMDA antibody was positive. So always don't think that NMDA is a standalone situation. You may have associated overlapping syndrome. It's called a dual positive overlapping syndrome. In NMDA, you can have MOG or aquaporin. For MOG and aquaporin 4 are demyelinating diseases. Okay, and GAD can be associated with GABA A or glycine. So this is the importance that just by doing one antibody, you might miss out on the other things. What is association? What is the trigger? Triggers usually infection. In NMDA, it's herpes simplex, it's Japanese encephalitis. Look out for teratoma in adults who had NMDA. Majority had ovarian teratoma, but in children, the sex ratio is almost equal, and you seldom come across an ovarian teratoma, especially in less than 10 years of age. You always have to hunt for a teratoma. You can do a chest and abdomen CT, and for boys, you do a testicular ultrasound. Teratoma, patients who have a very slow recovery, usually have ovarian teratoma, which has been discovered years later. I would like to highlight on that, which has been discovered years later, not immediately. And there are some studies that even a normal ovarian tissue was capable of producing NMDA autoantibodies. So the importance of this is you have a severe refractory NMDA encephalitis. So probably you will have to take out the normal ovarian tissue. It's very controversial. Look out for testicular teratoma, lymphoma. Diagnosis, you can do a CSF. What happens in the CSF? You may have a normal CSF, you may have mild pleocytosis, lymphocytic lymphocytosis, you may have a mild elevation of protein. You always have to do a serum and CSF. It has to be a paired sample. Paired sample means you take the serum, immediately you take the CSF together, send it to the lab, and always do it together. Why you have to do both serum and CSF and not serum alone and not CSF alone? Because children don't fit into one specific syndrome. And you have to, in NMDA encephalitis, serum is not positive, CSF is positive. In LGA1 and MOG, serum is more sensitive and not CSF. That's why you have to do both. But we have an issue where constraints.
എന്ത് പറ്റി?
നെറ്റ് കട്ടായതാ.
പുള്ളി ദേവസ്യ പോയെന്നോ?
നെറ്റ് പ്രോബ്ലം.
Welcome, Dr. Ananthakeshavan, our immediate National Vice President to our AAP meeting. Dr. Ananthakeshavan, sir. Dr. Ananthakeshavan.
Good evening.
Good evening. Good evening. Welcome to our team program.
Yeah, both folk were very good. Hypertension and NMDA.
Hello.
Sri Prasad, good evening.
I lost my connection.
No issues, sir. No issues, sir. Some part and parcel of online program.
The talk is over? No.
No, not over.
Treatment is yes, yeah, waiting for treatment. Okay.
Yeah.
Can you see my slides?
Yeah, it's coming.
All right. So always do the serum and CSF. Diagnosis, you do the serum and CSF, and you have to do a EEG to look for slowing. You can have delta brush where there is a slowing and a brush-like thing on top. It looks like a toothbrush on top. This is the brush, delta brush. MRI brain may show inflammatory changes, may not show inflammatory changes. If it is normal, well and good. And this is one MRI finding where there is a lesion, there's a diffusion restriction. That is a hyperintensity in the medial temporal lobe. This is in a seronegative autoimmune encephalitis. This is in this external capsule, okay, where in this case also it was a seronegative autoimmune encephalitis. You can do a CT chest, abdomen and pelvis. Look out for ovarian teratoma through transvaginal abdominal ultrasounds or MRI abdomen. Ovarian teratomas are microscopic and hidden, so it can be difficult to identify them radiologically, and especially ovarians are difficult to identify in less than 2 years. Diagnosis, serum and CSF has to be done. Look for the antibodies. So what happened to our case? Our child went to the ward and had seizures, started an AED and shifted to ICU and had status epilepticus. Now, next question is which AED to start and how to treat a status epilepticus. AED, there are no definite AEDs, but of late, there are some inclination towards sodium channel blockers because they have anti-inflammatory mechanisms. So if we are treating autoimmune encephalitis, always give us sodium channel blockers, but further studies are required for it. Refractory seizures or relapse is seen. When do you expect a refractory seizure relapse? When there is status epilepticus, cortical abnormalities, and focal neurological deficit. What is the protocol for treating status epilepticus? There's no other protocol but the standard protocol. You may use ketamine, even though ketamine is an NMDA antagonist. Now, our child came with NMDA positive, CSF positive, and EEG showed epileptiform abnormalities, treated on IVMP and IVIG. The next question that comes, which are the first and second line treatments, and how long to treat, and how long will you wait to look for the response? Treatment is IV methylprednisolone, 30 mg per kg, 3 to 5 days, max of 1 gram, followed by a combination with IVIG, and then you can give oral steroids at 1 to 2 mg per kg per day, taper over 6 to 12 months. Plasma Parexix can be given. One good combination is IV methylprednisolone and plasma. Plasma, but usually less than 20 kgs is really difficult and a lot of complications. And if there is no significant improvement in the next 10 to 14 days, you go to the second line treatment. And usual duration of maintenance therapy lasts 6 to 12 months. After 10 to 14 days, no improvement, go to the second line drugs. The second line drugs is rituximab, cyclophosphamide, some give intrathecal methotrexate also. Cyclophosphamide concentrates on the B and the T cells. They are given monthly, and rituximab is anti-CD20. It concentrates on the plasma cells, but one thing is that it doesn't concentrate on the long-lived plasma cells, so it might not eradicate them. So this is the source of a chronic autoimmune encephalitis. Bortezomib, this regimen has been borrowed from the adult multiple myeloma treatment, and this has been used in refractory anti-NMDAR encephalitis. This is a 2020 journal, and this is the regimen that has been followed. Bortezomib destroys the memory B cells, and that is why it has an edge over rituximab. Tolcizumab is anti-interleukin-6 receptor antibodies. And now coming to the case, our child was treated, and then he had severe dyskinesia, tongue bite, decreased sleep, and agitation. This is a video of dyskinesia. So that is the child, and this is the child after treatment. Beautiful kid running around. These two videos has been borrowed by my friend Smilo from Aster MIMS. And because the dyskinesia is a very big problem in NMDA encephalitis. And how will you treat them? Sleep, you treat with benzodiazepines, clonidine, chloral hydrate, other sleep-inducing agent. Catatonia can be very refractory, and you will need high doses of lorazepam. Severe dyskinesia, you treat with tetrabenazine, botulinum toxin, ketamine, dextromethorphan. Tramadol has been tried because it's a non-competitive NMDA encephalitis. That is the catch point, that tramadol can be used, and long-term administration of isoflurane has been tried. Now our child cognition worsened. He was started on maintenance steroid on MMF. Child slowly improved. After 2 days, started telling his needs and was ambulatory. Now the next question is, what's the role of serum and CSF NMDA, and how will you look for the disease progression or remission? In this slide, I would like to say that there is no association of antibodies titer in serum or CSF to the disease correlation. Only guiding therapy will be the clinical assessment. That isn't short in the slides. And child had behavioral changes in Korea again, and repeat NMDA is strongly positive. What are the chances of relapse? How will you treat a relapse, and when to start a steroid sparing agent? This is one video again borrowed from my friend. This is a relapse case with a focal seizure. This is a focal seizure. You can see only the face, the lips is affected. So relapse is after 1 month of recovery, there is new neurological symptom or aggravation of previously thing. So what is the percentage of chance? Relapse is 12 to 13%, and it is lower in people who have been treated earlier and in people who have been given second line drugs. And you have to start a steroid sparing agent within 3 months of the initial therapy. How will you treat a relapse? You treat a relapse as a standard new autoimmune encephalitis. And steroid sparing agents are mycophenolate, azathioprine, methotrexate. These are the doses that can be used, and the child improved. And how will you follow up? The aim is to detect the late onset tumor. You should know that the tumor may not be seen immediately. You have to go behind the tumor and hunt it for the next 4 to 5 years with imaging. So this is a summary. This is a PET image of a child who had autoimmune encephalitis. This is before treatment. You can see the hypometabolism here. I want you to concentrate here. This is the hypometabolism where it is not much red. Red means it is a normal metabolism. You can see the red here. There's no red here, and the red has improved over this place. So this is the response to treatment. Thank you.
Thank you, Davidson Devsia, for an excellent talk on autoimmune encephalitis. So even though it is a rare thing, but once you come across the treat patient with the autoimmune encephality, you face a different aspect, different modality of investigation and different modality of treatment, sir. So regarding the investigation part is concerned, sir, even if you suspect a clinically suspicion of autoimmune encephality, whether you had to do or NMDA, MOG, or all the antibodies should be treated, or NMDA alone is needed. But to send a panel of antibody testing is needed, or you do a selective NMDA only? So
in resource limited, I would definitely say, to be on the practical side, send only a specific antibody. That in resource limited, you can, because the whole panel itself will cost close to like 30,000, which will not be affording. So in resource limited, definitely send only NMDA, I would say. If you're sending NMDA, please send a serum and a CSF NMDA, or at least a CSF NMDA.
What about aquaporin for thing, whether it's CSF, both are needed, or
it's serum? It's serum.
Aquaporin serum is CF is
serum.
Serum.
That is associated with the demyelinating disease. The thing, the catch is sometimes you can have an NMDA plus aquaporin, NMDA or MOG, NMDA with thyroid antibodies. So if you, unless you send all this, you will not know. You will be thinking, yes, I got the diagnosis, it's NMDA.
What will the cost for a aquaporin? So we have one patient there. How much the cost for that?
I think it's close to 8,000, 7 to 8,000, I think.
8,000. So regarding the management aspect, even the children with the female children with autoimmune encephalitis, even with the normal ovary, you have to suspect that can precipitate autoimmune encephalitis. So yes. Any change in modalities management, if you no other causes were identified, autoimmune encephalitis are in female child, whether you have to do anything specific for that? Even in normal ovary, if there is
yes, the normal ovaries, we have to document that, do all the basic work first and see for the response to treatment. If the response to, if a practical guiding point is first you give steroid and plasma, or steroid and IVIG. So you cannot give plasma and IVIG together, because if you do a plasma, all your IVIG is washed away. There's no point in giving it. If at all you want to give a plasma after IVIG, it should be after 21 days. So what we can do is give a steroid and IVIG, see for the response. If there is a beautiful response, give a steroid sparing agent, give oral steroids and start on steroid sparing agent for a couple of months and then taper it off in the next 1 year. But if you have refractory seizures, patient is in the ICU first itself, and the child has severe catatonia, dyskinesias, I would definitely urge you to go ahead with cyclophosphamide or rituximab. So once we start it, the response is beautiful. Female child, if all investigations are negative, you have started on second line therapy, give all symptomatic management, keep the child under follow-up, and at least do ultrasound abdomen and resource limited setting every year. MRI abdomen would be really difficult, PET would be difficult.
So if you treat if you are starting the steroid, whether we can wait for a response or we can simultaneously we have to start IVIG.
So there are two patients. Suppose there is a child who comes to you, talking to your OPD, suddenly has a seizure, and then within 2 days goes to the ICU and has refractory seizures. Such children, you will have to hit really hard. It's like fires. It's like brain on fire. It's like your house is on fire. You'll have to throw all your water that you have, every armamentarium that you have to throw it immediately. Otherwise, it's going to burn down. But another scenario is you have a child who's talking, comes to the OPD, has mild behavioral neuropsychiatric symptoms, or mild dystonia, some impairment like that, sleep is disturbed, and then child is admitted in the ward, child is okay, you do the investigation has come positive, you give steroids, within 3rd dose of steroid, child has improved properly, by 5th dose, child is close to normal, not fully normal, but close to normal, you wait for another 3 to 4 days, child is improving, child is always improving, then I think you can send the child home on oral steroids and see for the response. Mostly such children who have a very mild course come out really well.
So thank you for the wonderful talk. It's a very good discussion also. There are 2 questions there. One is, in your case, you have seen severe dyskinesia and abdominal movement. How will you practically treat that child? The child is improved dramatically, all movements disappeared. So what are the use of practical treatment what we can give for such a child? Second thing is that we have a couple of children with anti-TP2 antibody encephalitis.
Yes.
So we are giving steroid and also without much improvement. What's your protocol for treating anti-Hashimoto's thyroid encephalitis?
Yes. One thing is, when your body's immunity is boosted up, when your body's immunity shoots up, you can have all non-specific antibodies that can be positive. We have children who are NMDA positive, having thyroid antibodies, not on a higher level, not more than hundreds, not more than, some is borderline 90s, some 110 like that. If it is a proper Hashimoto's, you will see it in the 150s or 200 range thyroid antibodies. That is one thing. You have children who are ANA positivity, ANA IFA is positive, Smith antibody is positive, they'll be borderline positive, but it will be positive. So you will be scratching your head, what is happening? So whenever our body is, immune system is triggered, you will have all these non-specific antibodies who will come. Treat the primary disease, whatever it may be, the initial treatment is going to be the same, whether it's Hashimoto's or whether it's autoimmune encephalitis, you treat the primary disease. If you are in a doubt, wait for another 1 or 2 months, repeat the ANA and see. So what are the practical ways you give of treating dyskinesia? Dyskinesia, I would say, is anybody who has treated dyskinesia would say that it's one of the most difficult part of NMDA encephalitis to treat, because there are children who break the teeth, who bite the tongue lacerations are there. It's very difficult to treat. It's easier said than done. So one way is in the slide that I've shown, tetrabenzene can be tried. Tetrabenzene actually helps. Then you can give lorazepam benzodiazepines, tramadol. I don't have an experience. I've not tried. I was just going through the articles and saying, so tramadols people have helped. I've not used isoflurane, but yes, some of my friends have used isoflurane and it helps. So severe dyskinesia is really difficult.
Really problem. Trifenhexylin, how it is capacity?
Pardon?
Trifenhexylin, capacity.
Trihexyphenidyl.
Very difficult. And
Pardon?
any protocol waiting for anti-TPO antibody encapsulation, because we are seeing patients refer for higher center to follow up of treatment with long-term monthly IVMP.
Yes.
So we have to give every month, we have to give IVMP for how long they are not advising. So we are giving every month, they will come, we give them without much improvement. Any protocol for treatment?
This monthly IVMP, it has been tried in autoimmune encephalitis. Autoimmune encephalitis, thyroid Hashimoto's is a part of autoimmune encephalitis also. So is there a role of monthly IVMP? You may give it, but I would say that you have to give a long-term immunosuppressant. This monthly IVMP, they will improve, again they will go, and again you'll have to give this continuously. I would say if you want to give IVMP, that is what you're comfortable with, rather than giving immunosuppressant long term. I would say that you have to give it for at least 5 to 6 months. Monthly IVMP.
Okay, thank you very much. Can you mention something about the dual positive overlapping syndrome? You already mentioned it.
Yes. Dual. It is just. I'll show you that slide. Where is it? So this is a dual positive overlapping syndrome. You can have NMDA with MOG and aquaporin. GAD can be associated with GABA B and glycine. It just shows that it is not only one antibody that can be positive. You can have 2 antibodies of a defined autoimmune encephalitis. So this is the importance of doing the serum and the CSF. You can have MOG antibodies, you can have anti-thyroid antibodies of a significant level. The importance of MOG antibody is a demyelinating disease, and the response to steroids is really good. So if you have a NMDA with a MOG, then you can be little calm that this probably, you can pray that the child doesn't go into a very refractory case, because MOG antibodies is a beautiful response to steroids. It's a relatively easier disease, demyelinating disease.
Okay, thank you.
Thank you, Davidson. Thank you, Anandakeshavan, for active interaction and discussions. And I think it's an excellent talk on autoimmune encephalitis in day-to-day practice. So over to Sir Prasad for final comment. Thank you, Dr. Davidson Devsia and Dr. Amitso Singh for an excellent scientific piece for AAP Alappuzha. Thank you all.
Thank you, Joseph, for moderating the sessions. And today we had 2 excellent talks by 2 specialists of Aster Medicity. And we are so happy that AK sir also joined with us. And on this platform, AK sir, may I have a request to you? AK sir, another question, sir. Sir, can you be with us as a faculty for May 5th, World Asthma Day?
Okay, no problem.
Okay, sir. Thank you for accepting our request. And we are so happy that we are getting more participation, even though the number of attendance participations were slightly less today in comparison with the previous sessions.
The number of matters, the interaction and the acting is more important. So many programs are going on.
That's right, sir. So thank you, AK sir, thank you, Joe sir, thank you, Shanava sir, and for expressing our sincere thanks. I request our Reshma, Secretary of Alappuzha Academy of Pediatrics.
Thank you, sir. So first of all, maybe the reason why participants is the heavy rains we had. Maybe electricity was a problem. So I would like to thank Dr. Amitos Baidwan. It was an excellent presentation, sir, and it was very elaborate. And the 2 cases which you had mentioned, they were really interesting. And I would also like to thank Dr. Davidson Devasya. Sir, actually, we see quite a lot of cases of autoimmune encephalitis. And it was a new information that even with normal ovaries, we can have NMDA producing from the normal ovaries. So I would like to thank both the speakers for spending so much time with us, and also Ananda Keshavan sir, T.P. Jayaraman sir, Johnny Sebastian sir, and all the senior faculties who were present. Thank you so much, and a very good night.
Thank you. Good night.